The assessment of regional wall motion abnormalities, which is the hallmark for the diagnosis of coronary artery disease, is probably the most difficult thing in echocardiography. However, the good news is there's a lot of patients you can practice in because we see them very often. But we'll not only talk about regional wall motion abnormalities, we'll also talk about other things which are equally important, such as wall thickness or the echogenicity of the myocardium. So this will be the topics of this forthcoming chapter. Before we look at actual regional wall motion abnormalities and before we look at examples, we first have to discuss which segments we can find and how we can explain to someone else where we see a wall motion abnormality. First, we divide the ventricle into three different segments with respect to the long axis. We can delineate the basal segments, the midventricular segments, and the apical segments. But remember, since the true apex is probably further up here because we have foreshortening, we need to also divide the mid from the apical segment further up towards the apex. Here are now the short axis views, the corresponding short axis views at the base, at the mid, and at the apical level. Here too we divide the myocardium into different segments. The first segment, which is fairly easy to describe, is the septum because it's defined as the myocardium which lies between the right and the left ventricle. The septum itself is divided into the anterior septum and the inferior septum. Right adjacent to the anterior septum we have the anterior wall, followed by the lateral or anterolateral wall, the inferior lateral or posterolateral wall, the inferior wall, and then again the inferior septum. The same segmentation is performed also at the mid-level. At the apex, however, we only have four segments. We have the anterior wall, the lateral wall, the inferior wall, and the septum. The lateral region is now a combination of the posterolateral and the lateral region, and the septum is a combination of the anterior and the inferior septum. In other words, we only have one septal segment opposed to two. So how does this now translate to the apical views? Well, we have a segmentation into the basal, the mid, and the apical segments, and thereby we can describe different regions of the myocardium. This is the four-chamber view, so what we see here is the septum. Therefore, this must be the basal septum. What we see in the four-chamber view is usually the inferior portion of the basal septum. This is the mid-septum. We can see both the anterior or the inferior depending on how we tilt the transducer. And this is the apical septum. Here we have the lateral wall in the four-chamber view. Therefore, we have the apical lateral segment here, the mid-lateral segment, and the basal lateral segment. Here is the two-chamber view. This is the inferior wall. This is the anterior wall. Therefore, this is basal inferior, mid-inferior, and apical inferior. Apical anterior or distal anterior, mid-anterior, and basal anterior. Now let's turn to the three-chamber view. Here is the posterolateral wall. This is the anterior septum. Therefore, we can divide following segments: basal posterolateral, mid posterolateral, and here we have the distal posterolateral or distal anterolateral segment. Remember, we only have one segment. We have fusion of these two segments here. The apical septum, only one portion or one segment of the septum in the apex. The mid septum, which is usually the anterior septum we see here, and the basal, usually the anterior basal septum we see here. I know this all seems pretty complicated, but you can find this diagram also in your fact sheet. And when I show you examples throughout this course, I will repeatedly name the different segments, so you will see eventually it's not that difficult. Another way at looking at the myocardial segments is the so-called bullseye representation. I find this representation actually quite appealing because it gives you a very good overview of the specific segments. Here we are looking at the ventricle from the apex, and we have the myocardium unfolded towards us, and here in the middle we have the apical segments. Those are the mid segments, and here are the basal segments. You can then also see the different regions, the anterior, lateral, posterior, inferior, septal inferior, and septal anterior regions, and thereby describe each individual segment. This plot can then be color encoded for various different things, for example for the degree of contractile dysfunction, strain, or strain rate. So you'll be seeing this plot very frequently, not only in echocardiography but also in cardiology in general. I now want to introduce you to another model which is slightly different from the one I showed you previously, the so-called 17 segment model. The only difference to the previous model is that it has an additional segment here in the apex, the 17th segment, which corresponds to the supraapical region. Why is this model appealing? Because sometimes you have small infarcts which only involve the supraapical region. If you would use the 16 segment model, you would probably overestimate the size of the infarct. By using the 17 segment model, you can clearly demonstrate that only the supraapical region is really involved. For better understanding, here's an example, or two examples actually. A small infarct supraapical, another patient with a larger apical infarct. If you use the 16 segment model, you could not distinguish the size of the infarct simply by looking at the report or looking at the bullseye plot. For comparative purposes here, an overview of the two different segmental models. The 16 segmental model and the 17 segmental model with the additional segment here in the middle. To give you a better explanation what the segmentation of the myocardium is actually good for, I would like to first explain you or give you a brief overview of the coronary anatomy and start with the left coronary artery. With the left coronary artery, this is the stem or the left main coronary artery, divides itself into the circumflex branch and into the anterior descending branch, also called LAD. The LAD has diagonal branches which are somehow cut off here, which supply the anterior wall and also parts of the lateral wall, and septal branches which supply the anterior septum. The circumflex branch has obtuse marginal branches and the lateral branches, and they supply the lateral wall of the myocardium. The right coronary artery supplies usually this conduction system, the atria, the right ventricle, and has two important branches, the posterior descending branch, which supplies the inferior wall but also parts of the inferior septum, and the acute marginal branches, which also supply the inferior wall but also can supply the lateral portions of the myocardium together with the circumflex artery. So how do problems of the various coronary arteries now translate to the segmental models in echo? First, let's take a look at the four-chamber view. In the four-chamber view, we already said the basal part of the septum is the inferior basal septum, and that is supplied by the right coronary artery. The remaining parts of the septum are usually supplied by the left coronary artery, as well as the apical segments, apicolateral. The lateral segments are supplied by the circumflex artery and also by the LAD, so you will have a mixture of both arteries, the LAD and the circumflex, supplying this region here. If we take a look at the two-chamber view, the LAD supplies the anterior wall and the apex, while the right coronary artery supplies the inferior wall. The infraoapical region can be supplied both by the RCA or the LAD, depending very much on the size of the LAD. If the LAD is very large and if it goes around the apex, you will also have blood supply of the inferior apical segments by the LAD. In the three-chamber view, the anterior septum is definitely supplied by the LAD, and the posterolateral wall is supplied by the circumflex artery, but can also be supplied by the right coronary artery if we have a very large right coronary artery. So this segment can be supplied by RCA and circumflex, and this is usually supplied by the LAD, but can also be supplied by the circumflex artery if it's very large. So you have an overlap in this region here. If we take a look at the short axis view, we have the lateral and the posterolateral walls usually being supplied by the circumflex artery, the inferior and the inferior septum supplied by the right coronary artery, and the anterior septum and the anterior wall supplied by the LAD. But remember, we always have an overlap in these regions, and it depends very much on the degree or the size of the specific coronary arteries, which portions of the myocardium are supplied by which arteries. In the peristernal long axis view, we see the same picture as we see in the apical long axis view. One last thing I would like to emphasize, the right ventricle is mostly supplied by the right coronary artery. So, confused? Too much information? Well, I guess it's time that we take a more practical approach. So let's take a look at the segments that we can see from the peristernal approach. We'll start with the peristernal short axis. First of all, we'll take a look at the left ventricle just slightly below the mitral valve. So this would be the mitral valve here. Now we have the subvalvular apparatus here, but we do not see the papillary muscles yet. So we're at the base of the left ventricle. This here is the septum, which you can divide into the anterior septum, which is this here, and the inferior septum, which is this here. This is the inferior wall, the posterior wall, the lateral or posterolateral wall, and this here is the anterior segment, which is just in close proximity to the interatrial septum. Now if I want to see the mid segments, I have to tilt the transducer towards the apex until I see the papillary muscles, or just the tips of the papillary muscles. That's approximately here. And again, I have the septum here with the anterior septum and the inferior septum, the inferior wall. This is the posterolateral wall. This is the lateral wall, and this is the anterior wall. So very similar, actually the same segmental division as in the basal segments. Now if you want to see the apical segments, you have to tilt further down, but sometimes it's difficult to really get the apical segments from the same transducer position. So it's advisable to move the transducer towards the apex from the position, and then you will see the apical segments. Now we have the septum here. This is the inferior wall, apical inferior wall. This is the posterolateral wall, and this is the anterior wall here. So these are the segments that we can see in the short axis view. And next, we'll turn to the apical views to see how we can correlate the peristernal to the apical views. The apical segments can be divided as follows. This is the apical four-chamber view. Again, we have the papillary muscle here, and the region between the mitral valve and the papillary muscle is the basal portion of the left ventricle. Somewhere between the papillary muscle and the apex would then be divided again in two segments, the mid and the apical segments. Again, considering that we have some degree of foreshortening. And since this is the lateral wall and this is the septum, we can divide the following segments: basal lateral, mid lateral, and distal lateral, while this is the basal inferior septum or basal septum, which is usually cut in the region of the inferior septum, so it's the basal inferior septum, the mid septum, usually anterior, and the distal anterior septum. If we look exactly, we can see that we have a wall motion abnormality here, hypokinesia and some degree of akinesia here in the apex. So this would be an apical infarct, a scar, with the distal septum and the distal lateral wall involved. Now let's take a look at the two-chamber view. Again, we can divide a basal segment, a mid segment, and a distal segment. Since this is the anterior wall, this is basal anterior, mid-anterior, and distal anterior, while this is basal inferior, mid-inferior, and distal inferior, or some would also call it infra-apical. Again, here is the wall motion abnormality right in the apex, involving the infra-apical septum and the distal anterior wall. And then finally, the apical long axis view, again 3 segments. This is the papillary muscle, so downwards towards the valve is the mid segment, the basal segment. Then we have the mid segment here and the distal segments here. This is the posterolateral wall, and this is the anterior septum. So we have basal anterior septum, mid anterior septum, and distal anterior septum, while this is basal posterior, mid, and distal. Again, the wall motion abnormality can be seen here. So this is how we would perform segmentation of the ventricle. I know this all sounds pretty complicated and difficult to remember, but don't worry, you'll see plenty of examples, and I'll always come back to the segments and repeat them again and again, and I'm sure in the end it'll stick.